where and how we can become truly an Ayushman Bharat. The ambition is not just limited to a country. If I were to scale it up, I would say this is about 1/5 of humanity. This is about one of the largest chunks of people anywhere on the planet. And when we are healthy, when we are robust in our well being, we will be people who will also provide the engine of growth and stability for the rest of the world. So, thank you so much for all the wisdom and words that you have shared with us. And as we pivot to our panelists this session, we have, continuing from the previous session, we have Dr. Nishant Jain, we have Dr. Chandrakant Lahariya, who is from the WHO, the National Professional Officer for Healthcare Access and Protection. We have Dr. Shuchin Bajaj, who's the founder director of Ujala Cygnus Hospitals. Dr. Priya Balu, Senior Public Health Scientist from the Public Health Foundation of India, and Dr. Hima Divakar, again, carrying on from the opening session, and we will continue to hear from you, ma'am. Thank you so much for each of you for making the time. And the order in which we'll kind of continue this conversation, and I would like to start with Dr. Nishant Jain and then continue on with each of you. This session, for our viewers, we are looking at the challenges of healthcare delivery, the mechanism, and also the roadmap towards wellness. And I've kind of broken up that title slightly, and you will understand in a second why I have done it, because in the way the conversation will proceed. Let me just kind of put a few statistics in place for Dr. Nishant Jain to respond to. As of this morning, on the NHA website, we have 12 crores, 73 lakhs and counting e-cards already there since inception. And 1 crore 45 lakhs and counting admissions. In the last 24 hours, we've had 20,000 plus admissions that have already taken place. And these admissions have taken place across 24,643 impaneled hospitals. The last bits of the opening session were beginning to veer towards how do we look at the wellness centers, how do we look at the pathway towards wellness, and not necessarily everybody landing up into the 24,643 hospitals. Dr. Jain, the infrastructure is already there, and it will continue to get scaled up, both in the public and the private sectors. What's the roadmap, and how do you see the expansion of the health and wellness care centers? Because that's where really people should be coming right at the beginning instead of going into the tertiary level hospitals. Over to you, sir.
Thanks, Bobby. Thanks, and thanks for inviting me. So, as you rightly said, that people should first go to wellness center, and that is where I think the trick lies. Because even if we give the best health insurance scheme in the world, still it will not be successful if the primary care is not strengthened enough. And it's not only a matter of setting up of these primary healthcare centers, or the health and wellness center, now we are calling them. It's also the matter of making them operational and making people use it. So I think the biggest challenge for the government will be, in my opinion, will be creating this continuum of care approach with people. Because in some countries, for example, like in Thailand, you cannot go directly to a higher level of care until it's an emergency. You have to go through a path. And many countries have followed that. And then people have that discipline that, if there is something first, they go to the nearest center where they are registered, and from there they go forward. So I think that kind of system needs to be tried here also, where people could be encouraged to go to these health and wellness center first before they go up. Because right now, people feel more comfortable going to a bigger hospital. Like even if you come to some of the biggest hospitals of the country, you will see huge OPD, and many of that for very small conditions which could have been treated very easily at the nearest place. But people still feel more comfortable coming there. And that's what I think we need to control on that. And that is something which is very important. So, but I think so one part is, yes, the government has to work on scaling up fast. So we have, I think, 30 odd thousand health and wellness center being set up already, but we need to reach 150,000, and we need to move fast. But I think that the other challenge, which from my angle is very important also, is the financing of the health and wellness center. Because health and wellness center right now are financed through budget, like any government facilities finance, where you give us fixed budget and then the people can use the budget. So whether you see 2 patient or 200 patient, the budget is roughly the same. And there is no incentive or disincentive, so to say. But the countries which have done very good primary care reform, they have changed the provider payment also. So many countries, they use blended capitation, where, for example, instead of paying through a line item budget, you get money through per person who is registered with you in the catchment area. And then within that money which you receive, you have to provide the treatment. So those kind of things also becomes important. So what kind of financing reforms can also happen? I think they will need to go hand in hand, because even if you will build excellent infrastructure and teams to keep them motivated, to keep the systems much more nimble, you may need financing reforms, like government has done with PMJ, for example, where hospitals are paid based on the number of patients they treat and not based on some fixed money per year or per month. And that's where I think the money follows the patient. Similar thing, I think, not in terms of package rate, but in terms of maybe capitation or blended capitation, some kind of financing reform will be very critical if we need to make this a success. So I think that, so the roadmap for the government should be to have not only reform in terms of the infrastructure and the human resource, but it should be coupled with financing reform. And third, it should be linked with making people aware and creating systems so that people follow this path. And the backbone of all this has to be a strong IT system where you can track the patient across all level of care, whether being referred up or whether follow-up care at a downward level. Thank you.
Dr. Jain, thank you so much for that comprehensive response, because really you have broken down that roadmap towards health and wellness centers into 4 discrete buckets, which I will kind of then also request other panelists to respond to. And it's easy for me to kind of distribute this also. But really speaking, just to kind of capture it back for our audience, right now we are at about 30,000 health and wellness centers. Our ambition is to get to 150,000 of them. How we get there, how fast we get there is one thing to be delivered on, and that's a commitment. So we will see them. The sooner we see them, the better. But it will not matter if we have the 150,000, because even the 30,000 right now isn't still being utilized to the extent that we would like it to. And that requires a change in mindset. That is not a provider mindset that needs to be changed. That's already changed. It needs to be at the people who require services. How do we go about doing that? That will require a sub roadmap. How do we communicate that? And how do we ensure that there is a assurance of quality when you get to that health and wellness center that allows people to know that this is where they will get the best quality service for the problem that they have without it being escalated or deteriorated. And the more complicated part of it then is, how do we finance this, both the scale up and also the continuing utilization of it? And I'll come back to, and we have the expertise on this panel to kind of get back to answer those questions. Thank you, Dr. Jain, for laying out that roadmap. So let me kind of then pick it up almost immediately with the bit that you said, which is both a hallmark of success and also a nightmare. And this is where I turn to Dr. Shuchin Bajaj. A crowded OPD or a full hospital is also telling something. It tells a story of its own, that this is a place where everybody trusts and is likely to go to. And so the doctors must be good here, the facility must be good here, so there's more and more people coming there, right? And that kind of creates a kind of a spiral, more people gathering. And so technically the hospital should be happy. Are you really happy when there are lots of people crowding your OPD for minor ailments, or would you be happier if it was slightly decongested? From a private hospital chain founder and somebody who's interested in public health and the delivery of quality care, what's your perspective?
So, thank you very much, Dr. Bobby, for this. I think the behavioral change of the community that has come in post the pandemic is quite irreversible now. People don't want to go to hospitals, especially, and even in some cases, standalone clinics also for minor ailments. Definitely not hospitals. I get many requests from patients saying that, can you ask your doctors to see us at a standalone clinic or see us at home. Our digital health teleconsults have skyrocketed. So when the pandemic hit, we were not doing even one teleconsultation because, as happens with everyone, right? When they're too lazy to do anything, they justify a lot of things. So we justified ourselves saying that, oh, we work in rural, semi-urban communities. Our community is not ready to adapt to digital or telehealth. And we never made a shot at it. But when the pandemic hit, the lockdowns came in, and the electives and the OPDs went to zero, we started teleconsultations and digital health initiatives within 3 days flat. And now we are doing 35,000 teleconsults every day. So I am sure the community doesn't want to do it now. So it's not a question of whether I like it or not. I work very closely with the Delhi government on the Mohalla Clinic initiative. I was in the UK for a fellowship, and I had a lot of interactions and learnings from the NHS. So if you see how the NHS model has evolved, about just 20 years ago, in the late 80s, early 90s, almost 85% of all patients of COPD and diabetes had at least one hospital admission a year. Just 20 years ago, not too far. And now that number is down to 12 or 13%. They all are okay with OPD consults, because the how the NHS and the UK government empowered the GPs and the nurse practitioners. So when I came back, we started working very closely with the Delhi government, and we initiated the Mohalla Clinic initiative. When we started out, we thought that we would be able to take care of about 80% of all people who came in, and would not need to refer them to the hospital. Very happy to tell you that that number was way off the mark. We actually started out with around 60%, then we said no, 80%. I think initially would be good. And now that number is almost 96%. 96% of the people are being taken care of at the Mohalla clinic level, and they have no need to go to the hospitals, which they earlier used to do. So if you see a government hospital anywhere, you will see in the morning times, 9 a.m. to 3 p.m. approximately, it's so crowded that you feel that, the entire city has descended upon it. But after 3 p.m., it's like there's nothing there, because everybody's disappeared, all the OPDs are over, and they're only IPDs. So if you can actually take that load off the hospital and take it to a smaller clinic, or even better, to a digital health initiative, like the health and wellness clinics, or if they go digitally, I think it'll be even one step better. I think the hospitals can work in a much better and more efficient way.
Thank you, Dr. Bajaj. I mean, the way that you've kind of described it, that it kind of suddenly decongests at 3 p.m. It's almost like people are stopped falling sick, and that the clock has struck, and it's just because the OPD has shut down. And that is essentially something that needs to be managed. What's very impressive to hear, and I'm going to kind of take words and probably put words in your mouth. Perhaps around in February, March, you had 0 teleconsults. To today, you're looking at 30 to 35,000 teleconsults per day. And you're just
per month. Sorry, no,
we
are not.
So about 1,000 per day.
Yeah.
Right. 1,000 per day is also a significant number of teleconsults. That's a huge shift that's taking place, and you're just one hospital chain that's reporting it. And I suspect that would be the same for many other hospitals. I have a question that I will now direct that to Dr. Chandrakant. Okay, because yes, we are seeing people. We would like people to come earlier on. We would like people to kind of be doing the earlier treatment seeking or care seeking closer where they are at. But a lot of this irreversible change that Dr. Bajaj is talking about is also among people who have the means to access such services. A stable internet connection or a phone that is able to kind of handle a teleconsult kind of a thing. What happens to people who may not be able to use that facility? And we have a large number of people who still will need the primary care services, but still get forced into the tertiary level centers. How do you even begin to address that.
Thank you very much, Dr. John. And it's a pleasure to see you after a long time.
Pleasure mine, too.
We are having this discussion. We are in 9 months into COVID-19 pandemic. And pandemics are the realities of time. What matters that how we are handling the pandemic or what we learn from it. So this is exactly what is happening now. When we are talking about teleconsultations, the discussion before the pandemic was a lot to move toward teleconsultation, but there were no guidelines. So what happened with the challenge posed by pandemic, that on 25th of March or 26th of March, Government of India issued the teleconsultation guidelines. And now we essentially as a country have converted the pandemic challenge into an opportunity, which is the new way of providing healthcare services. And it has a potential in many senses. One, it is reducing the crowd at the healthcare facility, but we should also look from the patient or recipient's perspective, that people who have to go for a long queue, have to use public transport and other approaches, or different transport approaches, and then wait in the queue, now can get this at the convenience of their home. So this is a new beginning which has started. Now, as you correctly highlighted, that this benefit would reach only to some of the group people, like maybe top 20% of the population who can afford that kind of services and that facilities. But it is unlikely to reach to bottom 60%, so to say, or definitely not to bottom 20%, but not probably not to bottom 60% of population. And that's where the role of government comes, that strengthening the government healthcare facilities and ensuring the increased availability of primary healthcare facilities such as Mohalla clinics in Delhi or Basti Dawakhana will serve the similar purpose. Ultimately, the teleconsultation is a good idea. It will reduce the crowd at the healthcare facility, but may not be used for every citizen who does not have a smartphone or that kind of health phone. So the crowd which is reduced at any given healthcare facility is going to benefit those who cannot use that kind of service. But the teleconsultation or telemedicine services have opened a new door, and which should be utilized to provide access to healthcare service in the rural and remote areas. So this is broadly speaking about the question which you asked, that there is a role where people will automatically utilize some new provisions such as teleconsultation by the teleconsultation services in health sector. But definitely there is need for active intervention by the government to ensure that such provisions also benefit those who do not have such smartphones and other things. But I would also quickly want to take another 1 minute to reflect about the opportunities which are created by the pandemic, which is really a challenge. Pandemic has essentially highlighted the need or importance of smaller healthcare facilities. We know from the experience in the last 9 or 10 months that the countries which have handled the pandemic really well are the ones which has created a stronger primary healthcare network, such as Thailand, Vietnam. The countries which have created a public health infrastructure, so not only in the terms of government health infrastructure, but also public health services, preventive, promotive services. Whether those services are delivered by private sector or government sector does not matter that much. What matters, people need those public health services which should be provided. Has given us new learnings in terms of focus or strengthening primary healthcare service, irrespective of the sector which is providing, focus and attention on public health services, irrespective of service who is providing. And it still reminds us that to address inequities and to address the challenges which a poor population face, the government continue to innovate in this area. And that's where the role of the discussion in this conference, Ayushman Bharat program. We sometimes, or many people in general population think that Ayushman Bharat program is only insurance scheme, which is Pradhan Mantri Jan Arogya Yojana, while the health and wellness center related discussion, which we are discussing, are equally important. We need to keep focusing on that. I stop here.
Thank you. Thank you, Dr. Chandrakant. I mean, and you've raised two very excellent bits, and I will kind of take it in two different parts in the conversation. The first part, and thank you so much for kind of pointing out that there needs to be further intensification or further resolve to extend the service delivery points, whether it is through the Mohalla clinics or whether it's through the Basti Dawakhanas or even actually getting those 150,000 health and wellness centers in place. But this is where, before I go to Dr. Priya and ask her about the financing part of the question that in the roadmap that Dr. Nishant had earlier put, Dr. Hema, is this a point? I mean, and this is where I'm looking at your name, artist. I mean, and you're looking at skill transfer. And each time I kind of look at it, I kind of keep thinking that you're kind of moving this from beyond just the confines of walls, whether it be a primary healthcare center or a health and wellness care center, or a kind of some kind of a facility, to actually skills in the hands of somebody who could be delivering it closer home or closer to where the point of need is. How do you see this as an opportunity? Is there an irreversibility that you're also seeing in that trajectory, in the way that Dr. Bajaj had also pointed out, that yes, there is the use for teleconsultation? Is there now a point of irreversibility for delivering services closer to home than people coming out from there, especially for maternal newborn child health services?
Thank you, Bobby. I think the first sentence that I wrote in my diary when the concept of this skill transfer came in to my mind for digital skill transfer is that we want to create history beyond the geographies, because it's really shattering the geographical walls, because it was my dream to at least train 1 million healthcare providers to take care of the 30 million deliveries which are happening every year in the country. I said the numbers are not matching. And the new courses of midwifery, for example, which will just get 300 midwives after a span of 18 months. And what do the existing providers do? Where are their skills? And when we did the baseline study, even in the private sector, the knowledge base was like 90%, but the skill actually to do things was just less than 20%. So the demonstrative modalities, the digital skill transfer, actually giving them some homeworks, they have to be ready, they have to be present on the digital platform to showcase to us, to actually demonstrate by simulations. That is the way we went ahead. And retraining, re-emphasis, reaffirming, revisions were seamlessly possible, because to paramedical healthcare providers, low dose, high intensity. Can't tell them too much and overwhelm them, but we have to also, the retention power may be, marginally less, and we cannot be complacent after just doing one program and leaving them alone. We have to make sure that they sustain and retain what they have, the skill they have learned. And by repeated role modelings and this and that and the other, we can now 100% make sure that the skills indeed have been transferred. And 2 years ago, nobody was believing, and they thought that I was just crazy dreaming of 1 million healthcare providers to be trained. But now, because the COVID has come to my rescue and everybody has jumped onto the digital platform, and now they're saying, yes, this is the way forward. So we are very happy to have strengthened our endeavor to really make sure that more and more. So the capacity building, what we want to address through the digital platform, is very much doable. And it is, we have reached Impal, Sibsagar, corners of Uttarakhand, and everything sitting out of our office in Bangalore. And that has been a solid proof of that possibility with quality. So if this quality of capacity building for different cadres in fast track courses can be initiated, and they are placed in the health and wellness centers, it'll be a fantastic way forward. Even they can be trained to take the telecalls and video calls and do many things sitting with the patient sitting in their own homes and they sitting in the wellness center or in their homes. So this is very doable. Please do not underestimate the underprivileged rural women. We have many calls from them. They're very wise, and they always seek the support of their daughters and their sons to connect with us. So you can see how fast the time is flying. In another 10 years, these daughters and the sons are ones which are going to go into the reproductive age and further on to the NCD age, etc. So they are very tech savvy. So very soon you will see the whole scenario of the clientele who is tech savvy, and they can't do without a mobile in their hands, you see. So that is the culture that is coming into our country for sure. And we have to encash it and believe that If not now, very much in the near future, this is possible. And always there is a blended connect. Yes, 80% we can do by telehealth, but 20% need to come. So the crowds get diminished, the bottlenecking again, gets to the bottom line, and the 20% can efficiently be handled both in terms of the cost and quality. That's what we would like to place. And please connect and collaborate to just make this happen across the country, and in fact the whole of Asia. Bangladesh, Nepal, all are booking into the skill transfer courses and finding a huge benefit out of that. Yeah.
Thank you, Dr. Hema, and I'll come back to you very, very shortly. There are two people that have said similar things. I think almost everybody has sentiments of that thing, but I just want to capture, even though it sounds a little bit weird towards the end of a year marked by a pandemic, and COVID is something that is kind of on everybody's front and center, that COVID has come to the rescue, as Dr. Hema is saying, in influencing a certain kind of behavior. We know that COVID has distorted many of the current realities, but it also seems to be a pandemic challenge that is becoming an opportunity, as Dr. Chandrakant said a little bit earlier. Yes, we will kind of look at those as the silver linings in a very, very dark cloud, and we'll work that way forward. But as we do that, the complicated question, and this is where I want to turn to Dr. Priya, because if we have to increase the numbers of the health and wellness centers, and if the utilization remains indifferent, you still have fixed costs. Jumping off from where Dr. Nishant had just pointed it out, I want to look at you for some kind of a directionality in how we go forward. He kind of used the word blended finance and many other things in blended capitations. These are all big concepts. How do you want to simplify that and help us understand how we can go forward?
Thanks, Bobby. Thanks for your question, Bobby, and I'm delighted to be part of this really interesting panel, and I'd like to thank the organizers as well. You've asked me a complex question and demanded a simple answer, and it's kind of interesting. So let me begin by the story by saying that we have roughly about 150,000 health and wellness centers that have been allocated in the country, and it's an ongoing process. It's nothing new. It's something that the government had initiated, and we're really hoping that it will go forward. I'm going to flip back your statement by saying that yes, 2020 has been a very dark year for all of us with relation to health, and I think COVID-19 has flipped the pyramid around in the way many countries have been dealing with the pandemic. One of the very interesting things that we see globally is that there has been over 90% of the world, countries of the world have come up with disruptions in essential primary healthcare services as a result of COVID-19. And this is in primary care, 90% of the world's countries. So, you're talking about the big OECD countries who have established systems, whether it's the UK or Germany or Scandinavia or the United States. And then you're seeing this pandemic that is completely changing the way these countries have been prepared. And the first line to really buckle is their primary healthcare systems in many ways. So I think what COVID-19 has taught us is the importance of a grounded and a very, very strong, well-invested primary healthcare system. It's a wake-up call for all of us to pay very close attention to that. The collateral damage that has resulted as a result of neglecting primary care, where all our country health systems have been pushed towards managing COVID patients in hospitals of different denominations, has actually resulted in, your increase in NCD burden, COPD diseases being neglected. As a result of this, when the pandemic eventually dampens down with or without a vaccine, you're going to be dealing with new types of healthcare fault lines that you're invariably going to see. I completely agree with Nishant's comment that the funding of health and wellness centers has to be creative. The other thing that COVID has taught us is that countries like India, as well as Global South, can be very creative in their ability to respond to pandemic. So I see two very clear dichotomies. I see countries with strong health systems, who are traditionally powerful, faltering largely because of the expenses and the lack of primary care in many of these countries, or complex primary care mechanisms. And I also see countries in the Global South that include India, Indonesia, Bangladesh, Sri Lanka, who have been able to battle COVID using different kinds of innovation. And those innovations have come forth in the following ways. You have digital innovation that have shown very clearly that states can leapfrog health system fault lines as long as they have the ability to think a little bit outside the box. That's the first lesson. The second lesson is really more interesting to me because COVID has also given governments the ability to take risks in areas that they would have never taken risks before. And that includes dealing with digital innovation, dealing with non-digital innovation, coming back to what Chandrakant said, that 80% of our population still may not have access to smartphones or cell phones, and therefore a lot of this innovation also has to be non-digital. And the ability for both the public and the private sector to advertently or inadvertently work together. And I think that's taught us a lot about how we want to manage health in the future. To me, I think COVID-19 offers a great silver lining. It allows us to rethink our own health system blueprint and can see very, very clearly where our fault lines lie and where we can plaster the cracks and where we can build new foundations. So I think the building of new foundations has to be in primary care. We have to rethink the way we think about primary care. So if we are having 150,000 health and wellness centers and a fantastically agile digital ecosystem that is emerging in the form of diagnostic technologies, in the form of telemedicine, in the form of human resource skill building, we have to marry the two. And we have to use something like the National Digital Health Mission to be able to create those kind of integrative networks. What we need is integrated care, but integrated care that can allow for some kind of, I think, flexibility in how we want to deliver the care, as well as flexibility in how we want to finance that care. So I think we will have to create a system by which we have to allow a creativity in financing, whether it's blended financing, whether it's contractual arrangement, whether it's bringing in private players to finance some of primary care. We have to think outside the box. And I'll leave you with just one example. At the beginning of COVID, I was in Singapore, and they are a small island, no doubt, an average population of 5 million. But SARS had taught them such a heavy lesson. It had taught them the lesson that the bulwark of every health system, no matter whether it's a Confucian-funded healthcare system like Singapore, where the individual often takes the responsibility for your own healthcare, really arises from a strong primary healthcare network. So what they ended up doing was they have a very interesting model where primary healthcare in Singapore is mixed. You have public as well as private providers. What they did was to amalgamate to create what they call primary healthcare pandemic clinics, preparedness clinics. So when the first wave of COVID emerged on the islands through different flight routes, people had a first line of response to go to through these clinics, and in turn they were moved up the healthcare value chain. This system has blended financing. In other words, people could pay for private clinics using their Medicare and Medifund, which would in turn reimburse some of the private clinics. So, I think it's a combination of creative financing as well as creative amalgamation of the different kinds of heterogeneous healthcare providers that exist in a country like India. This is an asset, not a disability. And that's how we should think about it.
Thank you, Priya. I always try to see whether I can get a simple answer, especially when it comes to systems and financing, and it's not always as easy. But here's something that I want to kind of draw out for us, and then kind of go back in a round robin again with each of our panelists. One is this question mark about what we consider as strong health systems. Is it a legacy of many, many decades, even centuries of let's say, improved nutrition and absence of infectious diseases that allowed for a facade of strong health systems, which got ripped apart by the emergence of a novel virus, which may probably be the reason why certain other geographies have been able to respond quicker, especially when it comes to delivering care to a larger number of people. And the contrasts are in the global south. I mean, yes, we have a significantly larger problem, but we're also matching it up with a responsiveness that's been starkly different from the strong healthcare system countries. And that's something worthwhile to notice, because our resilience or our responsiveness is built on an everyday responsiveness to infectious diseases. And we have a well-oiled mechanism. Whether it is Nigeria or whether it's India, we are immunizing tens of thousands of people on an hourly basis. And so can we kind of scale up some delivery mechanism? Yes, we have a know-how, we have a chain in place. And so therefore, it may be a inflection point globally, and for us also to understand that some of the things that we have built up are actually assets, and we need to kind of leverage that. And leveraging that would also then give us significantly better benefit cost ratios. One is understanding that primary healthcare, for every rupee or dollar spent, you get phenomenal returns in disease continuum averted or morbidity averted. In fact, in some places, even mortality aversion is far greater if you just had the ability to take a blood pressure very early on, or take a blood sugar level or a urine sugar very early on, or even have a urine albumin done very early on. Those are the gateways which people would be missing out on and ending up in a tertiary care hospital with either a renal issue or a fully blown out cardiovascular event. And then it's a lot of costs, which either it goes out of pocket or an institution like Ayushman Bharat begins to step into place. So therefore, there is an opportunity. And figuring that out is going to be the opportunity that right now that we need to capitalize on. The second is how digital health and data begins to allow both at individual and at collective levels to be able to decongest and provide for an earlier access. And we can't do both without a ubiquity of diagnostics. There is only so much that you can do on digital health. We can see, but you need something more objective than that. And that is, I think, a missing piece. You can tell people, you can modify behavior, you can begin to formulate a diagnosis, but if you don't have objective evidence, we miss out on something that is critical. Somebody might say that I'm going to the toilet every 2 hours, I'm drinking a lot more water, but a simple urine sugar, in the absence of that, you don't kind of know exactly what you're hitting at. And so therefore, and this is to the WHOs, or this is to the Ayushman Bharats, this is to the health and wellness centers, this is to all of us, we need to begin to see how we have a greater push towards objective evidence also being generated at the first point of approach itself. And that all three need to be wrapped around with a skills transfer or skills enhancement that Dr. Hema has begun talking about. If we don't have that, it's pointless. We can have buildings, we can have the diagnostic kits, we can have all the infrastructure in place, But if you don't have the relevant skills to kind of make sense out of it, people are still going to be as badly off and still crowd hospitals in the tertiary care segment like before. So if we have to really make a transition, let's start the round robin again. What would be your wish list, Dr. Bajaj? What is your wish list today from a tertiary care center where you're seeing the transition, where you're seeing a silver lining? What is your wish list of the Ayushman Bharat for a roadmap which allows for you to do significant work and are not cluttered with your capacity?
So it's a question which I would love to answer honestly, if you allow me to, because I
Honesty is the best policy, sir.
So as an organization, see, we have always been the champions of Ayushman Bharat. We were the first ones to be impaneled. We were the first ones to do a cardiac angioplasty. We were the first ones to do a mitral valve replacement. We were the first ones to get golden certificates. In fact, out of the first 10 golden certificate hospitals, 5 were Ujala Cygnus hospitals. So we were the first ones to be impaneled in Delhi, even when the Delhi government had not taken Ayushman. So, I mean, we have been truly the champions of Ayushman Bharat just because of the fact that we feel out of pocket expense is something that is quite horrible. We have 60 million people slipping below the poverty line in India every year just because of healthcare costs. But as a matter of principle and policy, I do not like insurance-based healthcare at all. See, the incentives. So like you said, detecting a blood sugar level in time, right, saves so much costs. But in Ayushman, who's incentivizing me as a tertiary care hospital to detect that blood sugar? Nobody. So my incentive is completely misaligned to the patient's incentive. I will be incentivized if the patient comes to me with a heart attack. I will put in a stent and bill Ayushman or bill the TPA or bill the whatever government authority there is that, this is my cost and this is what you need to pay me. How does that help the patient except for the fact that he's not paying out of pocket? So a person who comes to me with a diabetic foot, and we are amputating 1 foot per minute right now for diabetes, right? He comes to me with diabetic foot, I amputate the foot, and I'm very happy that, I saved his 1 lakh rupees because he was having Ayushman coverage, so I did it free of cost. But is it really free? Right? He goes home, he's lost his job because he doesn't have a leg, he can't go to work. So all his future earnings that are gone now, what's that indirect cost of disease? That's lakhs and crores of rupees gone. And the scariest cost is the intangible cost. So when he's lost his job, he will pull out his children from school and send them to work. So future generations will be destroyed because I had no incentive to detect his blood sugar in time and to keep it under control, right? So I think the best use of Ayushman will be in the health and wellness centers, and particularly in the data that is being generated, because everything is paperless in Ayushman. That is a brilliant thing that has been done by the NHA, and the health stack that they've built up is beyond compare. It's amazing technology that they've used. Because right now the problem is we are very good at delivering healthcare. Indians are amongst the best, right? Dr. Hema is here, amongst the best gynecologists in the world, you can say. I mean, there would be nobody in comparison to her. But we are very poor at collating data, analyzing data, and writing good quality papers. The output of papers is negligible compared to the volume of patients we see. So right now the problem is we are treating everyone based on data that has been generated on the east coast of United States. We say that because this tablet worked well in a 6 feet 2 inch Caucasian who eats meat every day at every meal, this tablet will definitely work on you even though you are 5 feet 3 inches living on the east coast of India and eating rice all the time and have never tasted meat ever. But we'll say no, because this data is there. The data was collected and it has been used and we have no data. So Ayushman will give us wonderful quality data, and I think we have the opportunity to jump at least 20 years in the future just because of this, that now we can have predictive and preventive healthcare. We can actually go back and see that these 20 people suffering from diabetes had this particular parameter that was deranged, and all of these people with that deranged parameters 2 years ago went into renal failure. So now we need to look at them rather than everyone, right? So we can focus our energies on them, try and get their blood sugars under control. So the fact that you said use of data, preventive analytics, and the incentive to actually prevent disease, the incentive to work on healthcare rather than sick care, is something that needs to be pushed very aggressively by NHA. I have been talking to them multiple times. So even though we do tertiary care and large hospitals, but at heart, I am still a preventive care physician. I would love for people not to fall sick. That is what we want.
Dr. Bajaj, thank you for speaking from your heart, and thank you for truly bringing out costs that are not accounted for in the provisioning of, say, services like insurances, whether through Ayushman or through out-of-pocket expenditure. Because while you may avoid a catastrophic health expenditure, you still have a catastrophe on your hand if you've lost your foot, or if you had to kind of withdraw from work simply because now you've got a triple bypass and you have to kind of build up your body over a few months. So you may have a saving on one side, but that's not the entire costs. And that's where the push and the opportunity really is, to look at how we fully understand the incentives that are there, both from the providers and also from those that are needing the care. How do people understand that it's not just the cost, it's also the opportunity that kind of needs to be capitalized on? And this is where I look both to Dr. Hema and to Dr. Chandrakant. I mean, both of you, one from WHO, one trying to figure out how this works at the grassroots level. What's the policy guidance, what's the practice that you would want to see happen that gets you aligned to better outcomes rather than the ones that kind of Dr. Bajaj says, it's okay. I mean, the economics works out, but the costs are far too big and not counted at all. Both of you. I mean, Dr. Chandrakant, if you can start off.
Can I?
Okay, Dr. Hema, yes, go ahead.
Yeah.
Yeah, go ahead.
So the point about the research which Bajaj brought about is really, really crucial, because the Asian community as such and the trends happening in our part of the world are pretty much different from the West. And
I'll come back to the research part of it, ma'am. I will come back, because that's the point.
That is the cue I'm taking to define what works for us. So we need to document this, audit it, and see what's happening in our context to see what works. And I think moving forward, the point of care, detection of so many things, so many non-invasive, so many innovative methodologies where we can offer. So the skills that we need to transfer is not a rocket science. Even with a minimal, skilling, with these innovative equipment, point of care reaching us and we reaching them. So the right things, nipping it in the bud, the right things can be done at the right time. Speaking from my point of view in the space of women's healthcare, if every one of these 150,000 Ayushman Bharat wellness centers can keep all our pregnant women well, because pregnancy is not a disease process, they need to go there for their checkup, and 10% of them may need to be institutionalized for delivery. What is happening as of today is institutional deliveries are 90%, but the pregnancy care or the antenatal care is less than 20%. So that gap needs to be definitely bridged, because there are a lot of things, of course, pre-pregnancy also, but that is too ambitious a target. At least they're coming to us in pregnancy and we're pushing things like anemia under the carpet, not doing much for them. We are not testing for their diabetes in pregnancy. We are not even taking the blood pressure with the working apparatus. So all of these simple things of skilling, which can identify and target these women for a controlled care during pregnancy and for the entire lifetime beyond that. Because what starts for these young women in pregnancy will turn into an NCD within 2 to 5 years after delivery. So she has to be tagged. It is called a tag mechanism. This lady has to be tagged for her life, because if she is offered a preventive care, definitely 20 million diabetics who are running in the country as women with diabetes, who has originated from the pregnancy point of view, can be controlled. For this, we again need the data. Whenever we give such analogy to the government, they said, where is your data man? and very difficult for busy practitioners to invest a lot in research, but at least the digital technology has allowed us to capture whatever little we can, see the trends, see what is happening in our own community and where we have to plug with some very simple investments and cost-effective mechanisms to not let it snowball into something which will really cost too much and will be wasteful at the end of it for the next generation. Even the skill transfer, the way we do it digitally, is 50 times less costly than what the other skill community has been doing on site, but it's 100 times more effective. So something like this, we have to figure out our own novel jugaad way of doing things, which will be useful in the end. That's what I would like to say. Yeah.
Thank you, Dr. Hema. I mean, and before I get Dr. Chandrakant, I want to interject. I mean, this is a very simple things, and they have got far more outsized things. I mean, and I'm going back to the time that I used to be in a village, and there used to be pregnant young women sitting outside my clinic. I mean, a simple look at the hemoglobin, a urine sugar, a blood pressure, a simple test for syphilis. Which we can do many other things. And those are not things that can happen through a digital health stack. I mean, we should not confuse a pipe that transmits or can help aggregate a lot of information with the simple tech that generates this evidence. We can see and talk to a person, but we may not get this. And this is not just for the pregnant women. These are also scalable to everybody else who turns up. And so this is where I turn now to somebody who works with a normative technical agency. What's the advice that you would give, Dr. Chandrakant, from wearing both your hats as a public health professional who speaks in the public domain, also with WHO? How are you kind of suggesting that we move further down to deepen and earlier engagement in the primary care continuum?
Of course. So talking about Ayushman Bharat program, one of the biggest success or impact of the program is that it has brought attention on health from the top level political leaders. So now from both a union level and state level, health started getting attention starting 2018, and even before pandemic brought further attention on health. So that's the biggest success. At the same time, we need to remember that while we need to celebrate the success and Ayushman Bharat program, both arms have benefited number of beneficiaries, there are still challenges ahead. For example, number of policy prescriptions made in national health policy that investment in health should go from 1.15% of GDP to 2.5% of GDP, but we don't see it increasing. Similarly, the other health will not improve and health system will not strengthen unless there is an increased investment. And we know that between 2001 and 2002 financial year to between 2015 and 16 financial year, the state governments in India did not increase their investment on health. It stayed nearly stagnant at 4.5% to 5% of state budget on health, while the target is 8%. We know health is a state subject, and that's why state need to invest to improve health. Without going into details into this, what we also know that there is a lot of attention on strengthening primary healthcare. National health policy said that government investment should be going largely on primary healthcare, and of the total government spending, 2/3 or more should be going on primary healthcare. But that's not happening. So we need to continually remember these things. I want to close with one aspect which you reflected in your earlier interjection, that if somebody asks question whether the well-functioning health system were ready for this pandemic, and one may wrongly infer that the well-functioning system did not succeed in controlling the pandemic. I would argue that those systems which really struggled were medicalized care systems. They were not the healthcare systems. And so United States of America, if it is struggling because it's a medical care system, probably it's not a healthcare system. But if Thailand, Vietnam, or even some of the European country which has a stronger primary healthcare system, they worked really well. So I would like to close by saying that we always knew, we know that 80% of healthcare needs of the people can be taken care by the primary healthcare system. Pandemic has provided us another opportunity to bring focus on primary healthcare, and that's where we need to focus on health and wellness center component along with the PMJY if we want to succeed. And then there are other learnings which probably we need to, within these components, For example, the preventive promotive healthcare, the public health services, or mental health care services which have been highlighted. I would close with the final part that there has been success in Ayushman Bharat program. For example, one of the component is strengthening laboratory services. But we realized during COVID-19 pandemic that it's not enough whatever is available, and we need to engage private sector to rapidly expand the COVID-19 services and public health laboratory surveillance. So there are many learnings which we can derive, but a well-functioning healthcare system is one which delivers healthcare services and can definitely help in taking initial burden. No health system is fully ready to handle pandemics or any challenge.
Which brings me to Dr. Priya. I mean, you have the last word on this panel. And I want to kind of preface your comments with just this observation, that from the time that the Ayushman Bharat was in inception, we had the health benefit package. It got realigned. We have now a new, call it a phase 2 or a version 2 of the health benefits package. 23 specialties, 872 packages, 1,574 procedures. There's been talk about rationalization of packages, but doesn't quite seem to lead to that link that essentially minimizes the usage of these passages and is actually beneficial. All the things that we talked about, how do we kind of get that shift towards earlier, primary, closer to home care? I mean, what is it that you would want to see happen? And what's the kind of directionality that you would be pointing to?
I'd love to see a focus on integrated care. I think while the Ayushman Bharat has done a fantastic job in conceptualizing, response to tertiary care response across both high secondary and high tertiary care, the health and wellness centers haven't really been catalyzed to their full potential. What I'd love to see in the future is that vital link that links primary care to secondary and tertiary care, forming that crucial bridge. The second lesson I think that COVID-19 has taught us is that the states that have really responded well to COVID are states that have been able to coordinate all aspects of response in a cohesive manner. They have, whether it is a municipal corporation or the state government, or going beyond even the remit of the Ministry of Health. I think what we also have to understand is that the health system is not a vertical silo that exists by itself. It involves all these determinants of health which are multiple ministries. So states that have, whether it's Kerala or Tamil Nadu or other states that have actually pushed forward in their early and very good responses to COVID are states that actually took into account all these determinants of health in their response to COVID. So coordinated care is really, really important to make a health system function cohesively. The third lesson I think I would like to see is design. And, India's health system had a design, whether it was the early Bohr report, there was a design. We also had the legacy of a primary healthcare system. The bulwark of the Bohr report itself was primary healthcare, and subsequent national health policies have also, stressed that. But here we have the opportunity, given these 150,000 health and wellness centers that have been proposed, to rethink how we want to design primary care. Where does it lie in the blueprint of our own integrated care pathway? How can we integrate health and wellness centers to tertiary care? How can we integrate digital health into health and wellness centers where there is a paucity for health workforce? I mean, you stressed that, we are slipping away from the basics of health, a simple diagnostic test or a urine analysis. A lot of this is also simplified diagnostic innovations that have come into the market, the health market today. So for a mixed health system like India, it's very important to look at healthcare design in a very careful manner. It doesn't have to be complicated design, but simple design. And this is an opportunity by which we can cohesively come together and look at how to design a health and wellness paradigm that will integrate care for a mixed health system like India.
Priya, thank you so much. I mean, the points that you're making essentially allow me to sum it up. We have a chasm right now between tertiary care and what we think is passing for primary care. We need to understand and figure out what is our doctrine of health. To borrow from what Dr. Chandrakant said, we don't want a medicalized care delivery system. We want a healthcare system. For a healthcare system, we need an overarching doctrine which takes into account all our assets, whether it is taxpayer funded or whether it's going to be out of pocket. How do we deliver the basic minimums when there is a collective challenge versus how do we deliver personally aspired outcomes? A nose job is not taxpayer priority, but a pandemic is everybody's priority and everybody's resources need to be brought in. And these things need to be pulled together earlier than later. A stitch in time does save 9. And therefore, we need to figure out how we get to that earlier stitch in the first instance possible. Can we be opportunistic in picking up the signals earlier than later? We don't need klaxons or red lights flashing. We need the tiniest signals from the individual closest to her or his place of comfort to be addressed. And in doing so, we might actually be able to flip around the way we deliver health, which is not a sum of doctors, nurses, equipment, and procedures and a bunch of money, but it is going to be a lot of things intersectoral coming together to deliver a sense of well-being and of being productive in society. I thank each one of you for joining us in this panel. Dr. Nishant, who had to leave earlier, Dr. Chandrakant, Dr. Shuchin, Bajaj, Dr. Priya, Balu, Dr. Hema Divakar, thank you so much for sharing of your experience and of your wisdom. And as I hand over to Kamal, I want our audience to reflect on the need to communicate within among ourselves and also within our extended community, the urgency with which, or the fundamentality of seeking care earlier. Do not postpone something if your body is telling you something. Go get that checkup done, because it's better to have a blood pressure measured or something else addressed than have yourself in an intensive care unit, especially during difficult times. That is not a great bargain. Go ahead, listen to your body, pay attention, and get that earlier checkup done. Thank you so much for joining us. And Kamal, hand over the session back to you.
Thank you, Bobby. Namaste.
So thank you so much, Bobby, and I would request our esteemed speakers to just wait for a minute, because in the normal physical conferences we used to give our vote of thank or our memento for your kind participation, for sparing time. That can't be done much now, but we would like to present a digital memento for your participation, for your kind insights which you shared about how we can fix this the problem of healthcare in our country, and especially the primary healthcare and the the preventive healthcare, which has come out very, very clearly in this session. So may I request my team to present the digital mementos for our esteemed speakers. So thank you so much, Dr. Chandrakant Lahariya, for your time and taking the name from your book, Till We Win, which you have authored with Dr. Guleria recently on this pandemic. I would like to take that meaning beyond pandemic, and till we win against all that ails our health, and till we win the all the impediments of providing quality, affordable, and easily accessible health to everyone, we will continue our effort, and we would like to have your patronage with us. So thank you so
very
much.
Thank you very much. And rather, the book has been released publicly today, and it's authored with not only Dr. Guleria, but Dr. Kang, Gagandeep Kang also. And it's a book on health systems, actually. So thank you very much for bringing that.
Thank you. Dr. Nishant Jain, he has had to leave for some other meeting. So we are thanking him also for his kind participation. Dr. Hema Divakar, our own and a very strong champion of women health. We are very, very honored and privileged to have your continuous support and to give further kind of strength to our mission of achieving health for all. Thank you so much, Dr. Hema Divakar.
Thank you, Kamalji and IHW. Thank you.
Dr. Priya Balu, thank you so much for your time, for your insights, and definitely with your a lot of good recommendation coming out, we would take that forward to all possible forums, that how we can have a health, primary health system maybe as robust as Singapore, which you mentioned. Thank you so much.
Thank you very much.
Dr. Shuchin Bajaj, thank you so much. You really spoke about how we can prevent and avoid a lot of that which we normally don't count, and which create a disastrous impact on the lives, on the family of the people. So how we can look into more about taking care of health rather than taking care of the sick people only. So thank you so much for your insights as always.
Thank you very much. Thank you to everyone.
Thank you so much. Thank you all the speakers.